hi guys, welcome to today's session. Today we are going to talk about the surgery revision session, and in this we are going to have a comprehensive discussion about quite a bit of topics. So all the topics we are going to discuss in quite details, and these are going to be done in the form of a couple of images. Okay, so let us begin and let us talk about our first image for the day. So what you're basically seeing over here, this is a patient who is suffering from bedsore. Okay, what are you basically seeing over here? That there is a patient who is suffering from bedsore. So let us talk about this bedsore. Bedsore, it is also referred to as your pressure ulcer, okay, or a trophic ulcer or a pressure ulcer, whatever. So that is what is called as a bedsore. Now let us first understand why does this happen. So most probably in this particular patient, what is the cause? So the patient must have got immobilized. The most important predisposing factor for the formation of a bedsore is immobilization. Okay, immobilization. Now what can be the reason for this immobilization? Okay, so what can be the reason for this immobilization? Either the patient is having some pelvic fracture, or let's say the patient is developing some, like in a post-operative state, in the post-operative patients when the patient cannot move, or the patient is having some kind of paralysis where the patient cannot get up from the position and cannot move and go to the different places. So immobilization is one of the key features for the development of the bedsore. Now what happens when the patient is immobilized? The pressure in the subcutaneous tissue increases. Okay, so because the patient cannot move from its place, the pressure in the subcutaneous tissue increases, and as the pressure in the subcutaneous tissue increases, if at all this particular pressure, it rises to more than 30 millimeters of mercury. If at all it rises to more than 30 millimeters of mercury, then what is going to happen? Then this 30 millimeters of mercury, this is what is called as a capillary closing pressure. What is this? This is what is your capillary closing pressure. If at all the pressure rises above this capillary closing pressure, what is going to happen? The skin necrosis is going to happen, and there is going to be the ischemia of the subcutaneous tissue, and ultimately what is going to happen? This area will suffer from ischemia, and finally we will have a formation of a bedsore. So this is a pathogenesis which you need to understand. This is what is present in the formation of a bedsore. Now what is this capillary closing pressure? What does this signify? Capillary closing pressure means a pressure above which the capillaries are closing. So obviously if at all the capillaries are closing, they will no more be able to supply the blood to the overlying skin, and because of this overlying skin will develop necrosis and gangrene and all those stuff. Okay, I hope you get this particular point. This is what you understand by a bedsore or a pressure sore. Now a very important question which they tend to ask you quite a lot of times is, what is the most common site of this? Okay, now if at all you have not gone through one particular table in the Levin Bailey, you might answer it as a sacrum, but that is a wrong answer. So please understand the most common site of a bedsore is ischium. Okay, ischium is the most common site, and they have asked this quite a lot of times, like a couple of times they have already asked this. So there is a probability now that in the question ischium will not be one of the options. Then you need to understand the second most common. Please understand the second most common site where the bedsore can occur is a greater trochanter. There's a greater trochanter. This is the second most common site for the development of a bedsore. Are you understanding my point? This is the second most common, and then comes the third most is your sacrum, guys. Okay, so the third most common site for the development of a bedsore is your sacrum. So this is a sequence which you need to understand, which you need to remember. Okay, right. Then okay, now let us also understand the classification of a bedsore. So you can classify the bedsore into class 1, 2, 3 and 4. So let us understand the classification of bedsore. What is the classification of a bedsore, guys? So you can have either class 1, class 2, class 3 and class 4. So, or whatever, the stage 1, stage 2, stage 3 and stage 4. Now what is included in the stage 1, guys? What is included in the stage 1? So in the stage 1, what you have a non-blanchable erythema, okay, with no breach in epidermis. So are you able to appreciate it? There is absolutely no breach in the epidermis, but all you have is a non-blanchable erythema. Then in the stage 2, what do you get? In the stage 2, you get that there is a partial thickness loss. There's a partial thickness loss of dermis and epidermis. Okay, so I hope you get this point. A partial thickness loss of a dermis and the epidermis. This is what is there in the kind of the stage 2. Then what do you have? You have a stage 3. In the stage 3, what do you get? You basically get a full thickness loss. What do you get? You get a full thickness loss of dermis and epidermis, but this is only till the fascia. But here what is the thing? The fascia is not breached. You do not go beyond the fascia. You are only reaching till the fascia, not going beyond the fascia. And finally what you have in the stage 4, the fascia has been breached and you are going till the underlying muscles and the bones. So here the fascia is breached and you're going till the underlying bones and the muscles. Underlying bone and muscle is exposed. Okay, so I hope you get this point. So these are the important points regarding the bedsore. Now finally, what about the treatment? So how will you manage a patient of a bedsore? Management of bedsore. Okay, so first you will have to go in for a debridement. Whatever the necrotic tissue is there, you will have to go in for a debridement. Okay, so you go in for a debridement. Whatever the necrotic tissue is there, you go in for a debridement. Once you're done with the debridement, you're taking off the slough and everything. Then what you basically do, you apply something which is called as a negative pressure dressing. So what do you apply? You apply negative pressure dressing or a suction pressure dressing or something like that. So you apply a negative pressure dressing. So there's a debridement, followed by this you have a negative pressure dressing, and yeah, that's what you need to do. So this is what is called as a vacuum assisted closure or vacuum assisted dressing. That is a vac dressing. What is the contraindication for applying this? What is the contraindication for this? So if at all, let's say there is an active osteomyelitis, or if at all the slough is present, or you suspect that this is a patient who is having a malignancy. So these are the points where you will not apply your vacuum assisted dressing or a vac dressing. Okay, so I hope you got this point. I'll just quickly revise what is a bedsore. Bedsore is a kind of condition which occurs predominantly because of immobilization. So let's say the patient is having a pelvic fracture or a post-operative patient, or the patient has developed a paralysis, and because of this what is happening, the pressure is kind of building up in the subcutaneous tissue, which increases. The pressure increases above the 30 milliliters of mercury, which is also referred to as a capillary closing pressure. And after this, because the pressure is above the capillary closing pressure, you develop the skin necrosis or the ischemia and all those stuff. And because of this, we develop a bedsore. Now, I told you the most common site is the ischium, the second most common site is the greater trochanter, and then comes your sacrum. And the classification is important. In the first, you get a non-blanchable erythema. That is what you need to understand. And there is no breach in the epidermis in the stage 1. In the stage 2, there is a partial thickness loss of the dermis and the epidermis. In the stage 3, there is a full thickness loss of the dermis and the epidermis. But here, the fascia is not breached. You do not breach through the fascia. In the stage 4, the fascia is breached and the underlying kind of bones and muscles are kind of exposed. Okay, so this is about the classification of the bedsore. How do you manage it? So you go in for a debridement, followed by this you put a negative pressure dressing, followed by this you go in for a vac dressing. Negative pressure or the vac dressing, one and the same thing. What are the conditions where they are contraindicated? So the vac dressing is basically contraindicated in the acute osteomyelitis, if at all the slough is present at the base, or let's say in the malignancy. So these are the places where it is contraindicated. Then Okay, so let's go to the next image, guys. So here what you have an image of a particular maneuver. So what is this particular maneuver which is being performed? So this is what is called as a log roll maneuver. What is this? This is your log roll maneuver. Now what you need to understand by this is why this is being done. So let's kind of understand what is the aim. What is the aim of performing this particular maneuver? You want to evaluate the back of the patient. Okay, so you want to evaluate the back of the patient. This is what is the aim in the log roll maneuver. Now how is it performed, how many people do you need, and all those stuff. So in this so how many people are needed? How many people are needed to perform this particular maneuver? So there are 3 people who are responsible for rolling the person, and there is 1 person, like the 4th one. The 4th person is basically there to kind of check or evaluate the back. So in all, how many total people are required? Please understand the total people which are required are 4. Out of these 4, 3 are basically to roll the person and 1 is basically to evaluate the back of the person. So if they ask you how many people are needed to roll the person, the answer would be 3. If they ask you in all how many people are needed to for the log roll maneuver, it is 4. Okay, I hope you get this particular point. Now you need to appreciate that this log roll maneuver, it is a part of your secondary survey. Okay, it is a part of your secondary survey, right? That's the first thing which you need to evaluate, which you need to consider. And the another important thing which you should know is that what is a contraindication? When will you not perform this particular log roll maneuver? So if at all the patient is having a pelvic fracture. So in the presence of a pelvic fracture, you will not perform this log roll maneuver. Do you understand this point, guys? So yeah, this is how you basically evaluate the back of the patient, and this is how you basically perform these particular steps. Okay, right. Now moving on, and let's talk about this. So what are you seeing on your kind of figure is, or on your screen is, this is what is called as FAST. What is this FAST, guys? FAST basically stands for focused assessment sonogram for trauma. Okay, what does it stands for? It stands for focused assessment sonogram for trauma. Now many times students confuse this assessment and they mark it as abdominal. So it is not abdominal, guys. Okay, the first thing which you need to understand is that what is FAST? FAST is basically a focused assessment sonogram for trauma. Now if I just ask you, like in a simple words, what exactly is a FAST? So FAST is nothing. It is basically a USG which you are basically performing in the emergency room. Okay, so it is basically a USG which you are basically performing in the emergency room. Now what is the aim? Okay, if I just ask you, what is the aim of performing a FAST? The aim of performing a FAST is that you want to have a look at the intraperitoneal fluid. Okay, you want to have a look at the intraperitoneal fluid. Okay, now what you need to understand is that normally, like in you and me, when you are not suffering from any trauma, do we have a major amount of the intraperitoneal fluid? The answer is no. But if at all we are able to detect some amount of, a significant amount of the intraperitoneal fluid in the abdomen just after the patient has suffered from a trauma, it indirectly indicates that okay, there has been some injury in the abdomen. Because of this, what has happened? Because of this, because of this particular injury, what has happened? That there has been, let's say, a breach in the artery, or let's say there is a breach in the intestine, and because of this, there is a kind of fluid or whatever the stool has accumulated inside this particular abdomen, which is detected on the FAST as an intraperitoneal fluid collection. Okay, I hope you get this particular point. This is the aim of it. And if at all the FAST is positive, it means that there is a significant amount of the intraperitoneal fluid. What is the minimum amount which can be detected by the FAST? It can detect 100 ml. Now Levin Bailey basically writes 50 ml, but by taking into consideration all the resources together, you can safely mark it as 100 ml. Okay, I hope you get this particular point. Now how do you perform this particular fast? Okay, yeah, literally, how do you perform this fast? So you take up your USG probe and you keep it at 4 positions. What are the positions where you keep it? So you keep it in the epigastric region, you keep it in the right hypochondrium, you keep it in the left hypochondrium, and you keep it in the pelvic cavity. Okay, so these are the 4 locations where you have to keep your probe. So let us kind of evaluate where do you keep your probes. So in the fast, the probe is to be kept in epigastric region. When you keep the particular probe in the epigastric region, what are you looking for? You are basically ruling out pericardial tamponade. Okay, so you're ruling out pericardial tamponade. When you're keeping the probe in the right hypochondrium, you are ruling out any injury to the liver. When you're keeping the probe in the left hypochondrium, you are ruling out any injury to spleen. When you are keeping the probe in the pelvic cavity, you are basically looking for any pelvic collection. The very reason for this is, what is the very reason for this? Because anywhere in the abdomen, if at all, let's say there is an injury, what is the fluid will be accumulated inside the abdomen? The fluid will get accumulated in the pelvic cavity. Are you understand my point? And that is why you are keeping the 4th probe in the pelvic cavity. I hope you get this particular point. Now, by this, you try to detect the intraperitoneal fluid. If at all it is significant, let's say it is more than 100, you say that the fast is positive. And then you basically manage the patients accordingly, right? Now, what you need to understand is that if after you have performed a fast, if I ask you, are you able to kind of tell me whether there is any pneumothorax or a hemothorax in this patient? The answer is no. Okay, so just by performing a fast, you cannot tell me whether is there any pneumothorax or a hemothorax. So what you need to understand is that there's something which is called as an E-fast. What is E-fast? E-fast basically stands for extended fast. Okay, what does this stand for? It stands for extended fast, that is focused assessment sonogram for trauma. Now in this, what you're doing, you're keeping your kind of probe at 6 positions. The 4 positions already discussed, and the 2 more positions are the right and the left lung field. Okay, so you're basically trying to evaluate the right and the left lung along with this. Okay, now what you need to understand is that when you're keeping your probe at the right and the left lung, what are you trying to do? You're trying to rule out pneumothorax and hemothorax. Okay, you're trying to rule out pneumothorax and the hemothorax. Now, what you need to understand, there are 2 signs. One is basically called as a seashore sign. What is this seashore sign, guys? Seashore sign is basically a normal finding. It is a normal finding which you basically get in the patient. Normal finding. Okay, it's a normal finding. That is, if at all a USG of a thorax is done in you and me, we will get this seashore sign. So what is this seashore sign? What is happening? There is a kind of a chest wall and there is lungs. So lungs are kind of expanding. They're coming and hitting the chest wall and then they're going back. So they look like the waves of the sea which are coming and hitting the shore and they're receding back. So this is what is called as the seashore sign. But let's say if at all there is a patient who is having a pneumothorax. In that patient, what we will get something which is called as a stratosphere sign. Okay, what we'll get? We'll get stratosphere or a barcode sign. Okay, so there we'll get a stratosphere or a barcode sign. Now what you need to understand regarding the stratosphere and the barcode sign is that air, this is kind of your artifact. It acts as an artifact. Okay, air basically acts as an artifact. So if at all, let's say there is an air which is present in the thoracic cavity, and if you keep a kind of a USG probe, it is going to be shown up as an artifact, and this is kind of detected like a barcode. Okay, so multiple artifacts, they are kind of appearing as a barcode or a stratosphere, and that is why it is called as a stratosphere or a barcode sign. So this is what you get in the pneumothorax. Okay, in the pneumothorax you basically get your barcode sign. The seashore sign, this is basically a normal finding in each and every individual. So this is all you need to know about your fast, guys. So I'll just kind of revise this for you. What is FAST? FAST basically stands for your Focused Assessment Sonogram for Trauma. That is the first thing. Now, what you are basically doing is, this is basically a USG which is performed in the emergency room. What you're trying to detect? You're trying to detect the intraperitoneal fluid. Now, if at all somebody asks you, can you detect a retroperitoneal fluid over here? So no, it is not accurate for the retroperitoneal fluid. Okay, it is not accurate for the retroperitoneal fluid. Now, even if the intraperitoneal fluid is kind of 100 ml, it can be detected by the FAST and you call it as a positive finding. And based on the clinical condition, you will evaluate and you will take the next step in the management of this patient. Now, you have to keep a probe in the epigastric region where you're ruling out the pericardial tamponade. Then in the right and the left hypochondrium, you're ruling out the injury to the liver and the spleen. And in the pelvic cavity, you're basically looking for the pelvic collection. But with this, you are not able to comment on a pneumothorax and your hemothorax. And that is why you perform something which is called as an E-FAST. What is this E-FAST? It is an extended fast. You keep the positions like your probe at 6 positions, 4 you already know of. The 2 more positions are the right and the left lung field. Then on the E-FAST, what you get a seashore sign and you get a stratosphere sign. So what is the seashore sign? This is what is a normal finding. Okay, so the seashore sign is basically a normal finding which is present in every normal individual, and the stratosphere sign is something which is called as in, like, air is there, and this air basically kind of shows up as in multiple artifacts or a stratosphere, and that is what you get in the pneumothorax, guys. Okay, so this is all you need to understand regarding the FAST, and yeah, that's it. Now let us move on and let us talk about the next image. So let's say that this is a patient who is coming to you after a road traffic accident. The patient was kind of driving a vehicle and the patient met with an accident. Okay, so after a road traffic accident, the patient is coming to you. Okay, just by looking at this particular patient, what you're able to appreciate that this is a patient who is suffering from a seat belt injury. You understand my point? So this particular marking, okay, this kind of a marking which you get, this is very much suggestive that the patient is suffering from something which is called as a seat belt injury. Now, there are a couple of things which you need to appreciate in the seat belt injury. What is the most common organ which is injured? So no brainer, guys, this is kind of simple. It is mesentery, guys. Okay, what is the most common organ injured? That is a mesentery of the bowel. Mesentery of the bowel. This is the most common organ which is injured in the seat belt injury. Now, what you need to appreciate over it is that why mesentery is kind of getting injured most commonly in the seat belt injury. So let's assume that this is a car which this particular person was driving, and this particular car, it comes to a standstill. Let's say meets with an accident, the car stops. Let's say the car was moving with 100 kilometers per hour. Let's assume that. Okay, now what is happening? There's a person who is sitting inside over here, and this person was also moving at 100 kilometers per hour. Right, kilometers per hour, but even he comes to a standstill along with the car. Why? Because when the car comes to a standstill, he tends to go forward. Okay, this particular person, he tends to go forward, but because he has kind of wore the seat belt is kind of restricting the movement of the person, and the person doesn't move, the person also comes to a standstill. I hope you're able to understand, right? If at all the person wouldn't have wore the seat belt, the person would have gone with 100 kilometers per hour and would have kind of hit the windscreen or something like that. Okay, I hope you're able to appreciate it. Now, that is fine. The person has also come to a standstill, but now what we need to go inside the abdomen of this particular patient. So I'm just trying to draw the abdomen of this particular patient. So what is there in the abdomen of the patient? Let's say this is your mesentery. Okay, so this is your posterior wall retroperitoneum, and this is your mesentery. Okay, so this is basically a retroperitoneum, and this is the there is an attachment of a mesentery. So this is a mesentery which is attaching with the bowel, right? And the mesentery is basically attached to a retroperitoneum, right? We all know that. Now, because the person was moving with 100 kilometers per hour, the intestine was also having a kinetic energy. It was also moving forward. The person has come to a standstill, but the intestine is still continuing to move. Are you understanding my point? So because of this, what is going to happen? There's going to be a traction which is going to get generated in the mesentery, and that is why there is going to be a kind of break in the mesentery. So this is just a mechanism why the mesentery is the most common organ injured in the kind of seat belt injury. If you understand, that's great. But even if you don't, please kind of make sure that you know that the most common organ injured in the seat belt injury. Okay, what we're talking about? We are talking about the seat belt injury. right? So the most common organ which is injured in the seatbelt injury, that is nothing but a mesentery of the bowel. Okay, I hope you understood this point. Now, okay, now what is the next most common organ? So what is the second most common organ or the structure which is injured? So the other organs or the structures which can be injured is the DJ flexure, duodenal, jejunal flexure. So what you need to understand is that the fourth part of duodenum, that is a retroperitoneal structure. Then the jejunum, that is your intraperitoneal structure. So wherever there is a transition between the retroperitoneum to the intraperitoneum, this particular junction is also very, very susceptible for the injury with the seatbelt injury. So we have already understood the concept. I hope you are able to connect the dots over here. Right, so that's all about that. Now what I'll do is I'll just tell you the most common organ injured, because it is again a very, very simple question, but many students don't kind of understand this. So let's talk about this. So what is the, if I just ask you what is the most common organ injured? Okay, so if I just ask you what is the most common organ injured, and if I give you in the blunt abdominal trauma, okay, in the blunt abdominal trauma, what is the most common organ injured in the blunt abdominal trauma? The answer is liver. Liver, oh, I'm really sorry guys, the answer is spleen. The most common organ injured in the blunt abdominal trauma, please forgive me, the answer over here is spleen guys, absolutely no doubt about it, no controversy, the answer is spleen. Now, in the penetrating abdominal trauma, if at all they ask you, what is the most common structure which is injured overall? Okay, so what is the most common structure which is injured in the penetrating abdominal trauma overall? The answer is liver. Please understand this point guys, okay? Because some of the guidebooks have given this wrong. Please understand the most common organ injured in the penetrating abdominal trauma overall, that is the liver. If it all this specifically mentioned in the gunshot wound, okay, if this specifically mentioned a gunshot wound, then the answer will become as small intestine. If they specifically mention a gunshot wound, then the answer will become small intestine. Okay, I hope you get this point. So the most common organ injured in the gunshot wound, that is the small intestine, and overall it is liver. Okay, so that is something which you need to understand. Now, okay, that's enough of it. Now let us talk about this particular image. So I'll just give you a clinical scenario associated with this guys. Okay, let's say there is a patient who is coming to you who is diabetic. So patient is suffering from diabetes mellitus, and the patient is coming to you with the clinical features of the patient are the patient is coming to you with signs of dysuria, pain, frequency, and the patient is also having something which is called as a pneumaturia. Okay, what do you understand by pneumaturia? Pneumaturia basically means that passing of the air in the urine. So patient is also coming to you with the pneumaturia, and you perform a X-ray and a CT scan in this particular patient. So you are having this X-ray for this particular patient, and then you are having this CT scan for this particular patient. So can you please tell me guys, what is the diagnosis over here? Now, if you say that the diagnosis of this particular patient is emphysematous pyelonephritis, you are absolutely correct. So what is this person suffering from? This particular patient is suffering from emphysematous pyelonephritis. So this is a patient who is suffering from an emphysematous pyelonephritis. Okay, I hope you got this particular point right. Now, right, so this is a patient who is suffering from an emphysematous pyelonephritis. So what we'll do, we'll just kind of cover a few important points regarding the emphysematous pyelonephritis. So what is emphysematous pyelonephritis? It is just a kidney infection which is having air in the parenchyma. So what is happening over here guys? There is a kidney infection where you have the air in the parenchyma. So this is what you mean by an emphysematous pyelonephritis. Okay, so renal infection or a kidney infection where you are having a air inside the parenchyma. Now, what are the predisposing factors for this? So the predisposing factors for this are diabetes mellitus. That is one of the key predisposing factor for this, right? So the clinical features I just told you. Now, important MCQ which is kind of asked quite a lot of times is, what is the most common organism which is causing this emphysematous pyelonephritis? What is the most common organism causing this? So here you can have right, so what are the most common organisms which can cause this? So if you say that the answer is Clostridium, that is your gas forming organism, that is false. That is not true, guys. Okay, so please understand, the most common organism which can lead to this emphysematous pyelonephritis is E. coli. Okay, do you understand this point? It is E. coli. It is not an Clostridium. If you answer Clostridium, it is going to be wrong. So please understand, the most common organism is E. coli. Now rest is fine. For the diagnosis, you can perform an X-ray or a CT, and you will find the air inside the kind of renal tissue and everything. And for the management, how do you basically manage this particular patient? So to begin with, what you do, you go in for a percutaneous drainage. You go in for a percutaneous drainage. Along with this, you go in for an antibiotics. Okay, so you go in for a percutaneous drainage. Along with that, you go in for antibiotics. And if at all the patient doesn't respond, or if at all the patient deteriorates, then you go in for your nephrectomy or a surgery or a nephrectomy or something like that. Okay, I hope you get this particular point. So that is something which is important. And the last point which I would tell you is, what about the prognosis? So this is a one which is having the bad prognosis, because here what is happening, the mortality is high. The mortality of this particular patient is high. It is as close to like 50 to 60% is the mortality in these particular patients, guys. Okay, so that is what the emphysematous pyelonephritis, what you're basically seeing on the X-ray. So you are seeing the air around the kidney, and this is a CT scan which is again demonstrating to you the air in the kidney. So what you need to understand is that, okay, air inside the kidney, it is very much diagnostic of your emphysematous pyelonephritis. Okay, so yeah, that's all about the emphysematous pyelonephritis which you need to understand. Now let's move on and let's talk about the next stuff. So here you have a person and you're having an X-ray and all the stuff. Now I'll just give you a clinical scenario associated with this. So let's say there is a patient who is having who was subjected for an upper GI endoscopy. So you performed the upper GI endoscopy in this particular patient. On performing an upper GI endoscopy, what did you like in the post operative period, you went to kind of examine this particular patient, and the patient complained, like patient looked like this. So here you are able to see something. I hope you're able to appreciate. Yeah, so please have a look at that. And then you ordered an X-ray in this particular patient, and on X-ray you found something which is wrong over here. And then you found that, yeah, you basically found something which is wrong over here. Other things are not very evident over here. Yeah, here also you can appreciate something. So what is this particular patient suffering from, guys? I'll just spill the beans over here. So what is this? This is a patient who has, during this particular procedure, the patient has suffered from an esophageal perforation. And this esophageal perforation has led to your subcutaneous emphysema. Okay, subcutaneous emphysema. Are you understand my point? So this is what is kind of being demonstrated over here. So these eyes, the eyelids, the swollen eyelids and everything, so this is basically the air which is basically present over here. Okay, so this is basically the air which is present over here. This is what you refer to as a subcutaneous emphysema. Are you understand my point? Yeah, right. And this is basically the hazy appearance of the subcutaneous tissue and the hazy appearance of the subcutaneous tissue, right? So this is the clinical scenario. Now let us talk about the esophageal perforation in detail, guys. Okay, so let's talk about the esophageal perforation. Now if I just ask you, what is the most common cause of an esophageal perforation? Okay, if I just ask you, what is the most common cause of esophageal perforation? The most common cause is iatrogenic. So this is basically while doing an instrumentation. You performed an upper GI endoscopy, and when you were just trying to negotiate your cricopharynx, just distal to the cricopharynx, you kind of ruptured this. Now why this is happening? Because your cricopharynx This is the narrowest part of the GIT. What is this? This is your narrowest part of the entire GIT. The diameter is only 13 millimeters. So sometimes what can happen when you're trying to negotiate a scope through this, you might, there might be a resistance, and you might kind of push a bit harder, and your scope might go through this particular esophagus and rupture it off. Okay, so it might happen, right? So this is what you understand about the mechanism of the iatrogenic injury, and this is in fact the most common cause by which the perforation can happen. What is the other cause of the perforation? So there can also be a spontaneous esophageal perforation, and the spontaneous esophageal perforation is something which is called as a Boyer-Heave syndrome. Okay, what is it called as? It is called as a Boyer-Heave syndrome. Are you understanding my point? So this is what is referred to as a Boyer-Heave syndrome. Spontaneous esophageal perforation, this is what is called the Boyer-Heave syndrome. Now, okay, I hope you got this. So this is your iatrogenic and all those stuff. So how will the patient come to you? Like, if at all there is an esophageal perforation, how will the patient come to you? So yes, patient will develop a kind of clinical features. The patient will have a chest pain, no doubt. The patient will have subcutaneous emphysema. And then you might also have vomiting. If at all you kind of perform an X-ray in this particular patient, you will be able to appreciate a subcutaneous emphysema. So how you are able to appreciate a subcutaneous emphysema? Just have a look at this, guys. Okay, so what is this? Are you able to appreciate that there is a hazy appearance between, this is your ribs, right? These are your ribs, and this is the skin margin. Now ideally these two should be very, very close to each other, but they're not. What is present over between this? So there is a lot of hazy area which is present over here. Are you able to appreciate it? This increased haziness between the ribs and the skin, this is something which is telling you that, okay, there is a air which is accumulating over here, and that is what you call as a subcutaneous emphysema. So on the X-ray you will be able to detect subcutaneous emphysema. Okay, so you will be able to detect a subcutaneous emphysema on the X-ray. Now if I just ask you, okay, right, another important finding which you might get on an X-ray is something which is called as a ginkgo leaf sign. So what is this ginkgo leaf sign, or a ginkgo leaf appearance, or whatever? So what is this ginkgo leaf sign? So in this, what is happening? There is air which is accumulated, air which is along the fibers of pectoralis major muscle. Okay, so here what is happening? There is an air which is accumulated along the fibers of the pectoralis major muscle, and this is what is referred to as a ginkgo leaf sign. So here you can detect a subcutaneous emphysema, that is fine. You can also have a ginkgo leaf sign, that is air along the fibers of the pectoralis major muscle. Okay, so yeah, these are about the X-ray findings. If I ask you, what is an investigation of choice for the esophageal perforation? The investigation of choice is a contrast enhanced CT scan, or CECT. That is the investigation of choice to diagnose a esophageal perforation. Now, let us talk about kind of the mechanism behind the Boyer-Heave syndrome. So let us talk about this Boyer-Heave syndrome, and let us talk about the mechanism over here. So what is happening over here? The patient is kind of having vomiting, and this vomiting is against closed glottis. Okay, so if at all the patient has a vomiting against the closed glottis, now most of the times this is associated with alcohol intake, but it doesn't mean every time the patient is drinking alcohol and vomiting, the patient is at increased risk of Boyer-Heave syndrome. It is not so. Now whenever we vomit, obviously our cricopharynx needs to open up, otherwise how will the vomit come out? If at all the patient is having a vomiting against a closed glottis, okay, if at all this is happening, what is going to happen? There is going to be an increase in the intraluminal pressure. So there is a rise in the intraluminal pressure, and because of the rise in the intraluminal pressure, two things can happen. Okay, because of the rise in the intraluminal pressure, what can happen? Two things can happen. Either there can be through and through rupture of the esophagus. So what do you understand by through and through? I mean that the entire esophagus is kind of rupturing off. Yeah, the entire wall of the esophagus is kind of rupturing off. This is what is called as a Boyer syndrome. Or there can be a longitudinal submucosal tear. So this longitudinal submucosal tear which is happening, this is what is referred to as a Mallory-Weiss tear. And in this patient, the patient is going to come to you with a hematemesis. I understand my point. So in the Mallory-Weiss tear, the patient comes to you with a hematemesis that is not associated anyway with the esophageal perforation. I just mentioned it over here because the mechanism of the Boyer and the Mallory-Weiss syndrome, it is exactly the same. The only thing is how the esophagus is responding to that increased intraluminal pressure. Based on that, we get either a Boyer syndrome or we get a Mallory-Weiss tear. Okay, I hope you get this point. This is how you will talk about the Boyer syndrome. So we have done with this. I'll just revise, concise whatever we have talked about till now. So I told you that esophageal perforation, the most common cause of it is iatrogenic. That is, you are basically performing an upper GI endoscopy, and when you're performing an upper GI endoscopy, you try to negotiate through the cricopharynx, which is in fact the narrowest part of the entire GIT. The diameter of this is only 13 millimeters. So if at all you try to negotiate it, you're not able to do it. So what is going to happen? It is going to rupture through the esophagus, ultimately leading to a esophageal perforation. I told you that there can also be a spontaneous esophageal perforation, which is referred to as the Boyer syndrome. What are the clinical features? The patient will get a chest pain, the patient is going to get a subcutaneous emphysema, vomiting. On the X-ray, what you will do, you will basically be able to detect a subcutaneous emphysema, and you can also have this ginkgo leaf sign. And what is this ginkgo leaf sign? So this is basically air along the fibers of the pectoralis major muscle. Then I told you that investigation of choice to diagnose the esophageal perforation is CCT, because we are trying to find the air, and yeah, like CCT is best investigation for the air. Then we have Boyer syndrome. I told you that Boyer syndrome, it is usually associated with an alcohol, but it is not so. The main kind of mechanism behind formation of a Boyer syndrome is that if at all the patient is vomiting against a closed glottis, so vomit will not be able to come out, there will be raised intraluminal pressure. Because of the raised intraluminal pressure, there can be a through and through rupture of the esophagus. If at all there is a through and through rupture, the patient is going to develop a Boyer syndrome. If at all there is a longitudinal tear along the submucosa of this particular esophagus, the patient will land up into Mallory-Weiss tear. Okay, I hope you get this particular point. So these are the important stuff which you need to understand. Now, right, so that's about the pathogenesis and everything about this particular Boyer syndrome. Now, lastly, what we are going to talk about, how will you manage? So if at all, let's say there is a patient who is coming to with a esophageal perforation, what you need to understand is, if at all the patient is presenting to you in less than 24 hours, if at all the patient is presenting to you in less than 24 hours, you go in for a primary repair. If at all the patient is not coming to you within 24 hours, after 24 hours, if the patient is showing to you, you cannot go in for a primary repair. Now you have to go in for a kind of diversion surgery. So what do you understand by this diversion surgery? Whatever the proximal segment of the esophagus is there, you bring it out. Then the distal segment of the esophagus also you bring out as a mucous fistula. And then there is a stomach which you have. So you perform a feeding gastrostomy or a feeding jejunostomy, whatever you feel like. Okay, are you understanding my point? So this is how you manage like the diversion surgery. This is how you done. You go for an esophagostomy, you go in for a mucous fistula, and then you have your feeding gastrostomy or a feeding jejunostomy, whatever you're planning. So if you're planning to use the stomach for the reconstruction of the esophagus later on, you might as well go in for a feeding jejunostomy, right? So this is how you manage a patient of an esophageal perforation. Now let's move on and let's talk about the next clinical scenario, guys. So here you're seeing an image. This is an upper GI endoscopy image. I'll just give you a clinical scenario associated with this. So let's say there is a patient who is coming to you with an upper GI bleeding. Okay, the patient is coming to you with an upper GI bleeding. What did you do? You performed a upper GI endoscopy. You performed an upper GI endoscopy in this particular patient. When you performed an upper GI endoscopy, you saw an image like this. Now what you're basically seeing over here, the surrounding mucosa, are you seeing any growth or something like that? No, right? It is kind of normal. Then what do you have? You have this one pinpoint source, and from here a lot of blood is coming out. So like a gush of blood is coming out. So here what is happening? The gush of blood is basically coming out, and yeah, this is what is a gush of blood coming out. And here you have on the upper GI endoscopy, what do you have? You have this, the surrounding mucosa is normal. So what does this suggest to you? What is the diagnosis of this particular patient? It's an important thing, guys. The diagnosis over here is, it is called as a dilophos lesion. What is this? This is dilophos lesion. So what is happening in the dilophos lesion, guys? There is a pinpoint source of the bleeding, and the mucosa is normal, right? So let us talk about why does it occur. So in the dilophos lesion, what is the cause? Okay, so what is the cause of this bleeding in this dilophos lesion? So what you need to understand is that there is a submucosal pulsatile vessel. And what has happened? The submucosal pulsatile vessel, this pulsatile vessel has kind of eroded through the mucosa. Okay, so this kind of pulsatile vessel has kind of eroded through the mucosa, and because it has eroded through the mucosa, we are having a bleeding. This particular thing, this is more on the lesser curvature. Why it is more on the lesser curvature? Because along the lesser curvature, what do you have? Along the lesser curvature, you have your left gastric artery. Okay, so you have a left gastric artery. So because any of the branch of this can torrentially start bleeding, and that is why it is more on the lesser curvature. Okay, I hope you got the reason for that. And what is this? This is submucosal pulsatile vessel. It is not some AV malformation or something like that. So now you have done an upper GI endoscopy, and you're actually finding just such kind of torrential bleeding which is happening. So how will you manage this particular patient? Now guys, many students tend to confuse with this. They say that we'll go in for an angiography with the embolization or something like that. That is not the answer. Here what you have to do, you have already done an endoscopy, and on the endoscopy what you're finding, you're basically finding a active bleed. You're finding active bleeding. So on the endoscopy, you're basically finding an active bleeding. So here what you have to do, you have to go in for a cauterization. You have to go in for an cauterization of that particular vessel. You have to cauterize that particular vessel first thing. Then what you need to do, okay, so first you need to cauterize. If at all cauterization fails, if at all this cauterization fails, then you have to go in for angiographic embolization. Okay, then you have to go in for an then you have to try this angiographic embolization. You have to try that. And if at all this angiographic embolization also fails, then what you have to go in for, you have to go in for a wedge resection. If at all the angiographic embolization also fails, then you have to go in for a wedge resection. Are you understanding my point? So these are the ways in which you have to manage this particular patient. First step is always you have to go in for a cauterization. You have already done an endoscopy. You're seeing a bleed. Just try to cauterize it. If it fails, you try to go in for an angiographic embolization. If that also fails, you have to go in for a wedge resection. What do you understand by the wedge resection? So let's say this is a part of the stomach, and let's say there's a bleeding which is happening from here. So what you basically do, you just resect this particular part of the stomach. If at all not, then you can also go in for a subtotal gastrectomy or something like that. Okay, I hope you get this particular point. Nothing great about it, but yeah, this is how you manage a patient of a dilophos lesion. This clinical scenario and this particular management is empirical to be known, and I hope you will know this. Okay, so with this, let's move on to the next question, guys. So here, let's say, I'll just first give you a clinical scenario. So let's say there is a patient who is kind of obese, and the patient is basically coming to you with malabsorption state. So the patient is basically having, malabsorption and kind of GI upset. Now what happened? The patient started to develop a bleed, but this time the bleeding was from the lower GI, so per rectal bleeding. The bleed basically stopped after some moment of time, and then you investigated this particular patient. When you did a, let's say, a barium enema in this particular patient, what did you find? You find a appearance like this. What is it? It is called as a sawtooth appearance. Okay, what is this? This is a sawtooth appearance which you are getting, and then you ended up performing an colonoscopy. So you performed a colonoscopy. In the colonoscopy, you were able to find these kind of defects in the intestinal wall from where maybe the diverticular has occurred or something like that. Okay, I understand my point. So what is the diagnosis of this particular patient? It is a giveaway question. It is a diverticulosis. What is the answer? It is a diverticulosis. Now what you need to understand over here is that this particular image is kind of important, very important. So yeah, it's pretty simple. I'm sure 90% of you guys must be knowing this, but please understand the sawtooth appearance. This is what is seen in the barium enema in the patients with the diverticulosis. Okay, so now let us talk a bit about the diverticulosis. Okay, so let's talk about the diverticulosis. Now if I just ask you, we get a diverticulum and the diverticulosis, right? So is it like a true diverticulum or a false diverticulum? So diverticulosis, we get a false diverticulum. First point, we get a false diverticulum. Now what you need to understand over here is that, okay, now if I just ask you, what is the most common site? Okay, what is the most common site of acquired diverticular in colon? Your answer would be sigmoid. So the point which I'm trying to make over here is that the diverticulosis, this is more common on the left side as compared to that of a right side. Okay, right side. But interesting feature is that if I ask you which diverticula is more likely to bleed, okay, so please understand this. That is true that the left-sided diverticulosis, that is more common as compared to that of a right side. That's true. I get it. But if I just ask you, which side diverticula is more likely to bleed? So bleeding is more associated with the right-sided diverticula. Okay, so bleeding is kind of more associated with the right-sided diverticula. You understand my point? So this is what you need to understand, a couple of features. Now, what can happen? There is something which is called as a presence of a diverticula, which is called as a diverticulosis. But there can be complications of this diverticulosis. So what can be the complications of the diverticulosis? This can complicate into, like, the patients can come to you with the bleeding as was in the clinical scenario, and they can also complicate into diverticulitis. So what is this diverticulitis? This is basically the infection and the inflammation around the diverticula. So there are two important MCQs over here, guys. If I just ask you, what is an investigation of choice for the diverticulosis? The answer is no doubt it is barium enema. But can we perform a barium enema in the diverticulitis? The answer is absolutely not. So here the investigation of choice in the diverticulitis is CECT, contrast enhanced CT scan. Are you able to understand over here? So investigation of choice for the diverticulitis is CECT. Investigation of choice for the diverticulosis is a barium enema. Understood this point, guys? Yeah, I hope you got this point. So yeah, this is what is the clinical scenario and the images and all those stuff regarding your diverticulosis and the diverticulitis. Right now, right, so that is all about a few important points regarding the diverticulosis and the diverticulitis. Now next, let's move on to the next question, guys. The next question which we have is, there is a patient who is having a cystic neoplasm of the pancreas. So what is the patient suffering from? The patient is having a cystic neoplasm of pancreas. What did you do? you performed an ERCP in this particular patient, and as soon as you cannulated the duct, you found an image like this. The image of that particular ERCP is given to you. So what is this? What are you basically seeing over here? This is what is called as a fish mouth appearance. What is this called as? This is called as a fish mouth appearance. And yeah, this is what is called as a fish mouth appearance. This is what is the diagnostic of your IPMN. Okay, so where do you get this fish mouth appearance? We get it in IPMN. What does this IPMN stands for? It is intraductal papillary mucinous neoplasia. What is this? This is your intraductal papillary mucinous neoplasia. Okay, so yeah, this basically stands for this intraductal papillary mucinous neoplasia. Okay, so let us kind of evaluate the cystic neoplasms of the pancreas. Okay, so let us have a brief chat about the cystic neoplasms of the pancreas. What are the cystic neoplasms of the pancreas, guys? So let's have a look at that. Cystic neoplasms of pancreas. So what are the important cystic neoplasms of the pancreas? You can have either a serous cystic neoplasm, SCN. This stands for your serous cystic neoplasm. Then you have your mucinous cystic neoplasm, MCN. It stands for your mucinous cystic neoplasm. And we have just talked about IPMN. So what does IPMN stands for? Intraductal papillary mucinous neoplasm. We have just written over here intraductal papillary mucinous neoplasm. So now let us evaluate the features about this. So please understand this: in the serous cystic neoplasm, this is more common in the females as compared to that of males. Great. What about the mucinous cystic neoplasm? It is much more common in the females as compared to that of males. The ratio of the females to males is much higher in the mucinous cystic neoplasm as compared to the serous cystic neoplasm. But in the IPMN, they are more or less equal. Like there is not much of a difference between the incidence in the females and the males and all those stuff, right? That's something which you need to understand. Now, what about the serous cystic neoplasm? If we talk about the distribution of the serous cystic neoplasm, it is equally present in the head, body, and the tail. Okay, so this is basically equally distributed in the head, body, and the tail. The mucinous cystic neoplasm, this is more common in your kind of the head, and this is okay. So mucinous cystic neoplasm, I'm sorry, this is basically more common in your body and the tail portion. This is more common in the body and the tail, more common than the head. And IPMN, this is mainly present in the head of the pancreas. Okay, right. Now there are few features which you get in the individual things which you need to understand. With the serous cystic neoplasm, what do you get? You get something which is called as a central stellate scar. What do you get? You get a central stellate scar, which is nothing but a starburst calcification. So this is also referred to as a starburst calcification, which you basically get on the CT scan in this particular patient. In the mucinous cystic neoplasm, what are the features do you get? So in the mucinous cystic neoplasm, you get something which is called as an eggshell calcification. Please understand this. Here you get an eggshell calcification. There's no such kind of a thing which is present in the IPMN, but you definitely need to remember that the central stellate scar and the starburst calcification is present in the serous cystic neoplasm, and the eggshell calcification is something which is present in the mucinous cystic neoplasm. Okay, I hope you got this particular point. Yeah, that's done. Now, next thing what you need to understand and evaluate is, so now let's talk about the presence of the mucin and the CEA. Okay, so I'll just write it over here again: serous cystic neoplasm, mucinous cystic neoplasm, and your IPMN. So obviously no brainer, man. If at all there is a serous cystic neoplasm, will the mucin be present over here? Obviously not, right? The mucin will be absent over here. What about the mucinous cystic neoplasm? Definitely it will stain positively with the mucin. The mucin will be present over here. What about the IPMN, intraductal papillary mucinous neoplasm? So definitely the mucin will be present over here. So it is just your common logic, man. I hope you get this particular point. Now, next what we want to talk about is about the amylase level and your CEA level. So what you need to understand is that amylase level, they are basically low in your serous cystic neoplasm, and they are low in the serous cystic neoplasm, and the CEA level is also low in the serous cystic neoplasm. What about the mucinous cystic neoplasm? Here the amylase level are low, but the CEA is basically elevated. And in the IPMN, both are high. That is, amylase also elevated and your CEA is also elevated. Okay, I hope you get this particular point. So this is what you need to understand, what you need to remember. Nothing else. Even if you remember this, you will be able to solve most of the questions regarding your cystic neoplasms of the pancreas. So I'll just revise it for you guys. The cystic neoplasms of the pancreas, they can be of three types. They can be serous cystic neoplasm, they can be mucinous cystic neoplasm, and they can be IPMN. Now, what we talked about, the serous cystic neoplasm, that is more in the females as compared to the males. The mucinous cystic neoplasm, that is again more in the females as compared to the males, but the ratio is much higher. And the IPMN, the males to the females ratio is practically the same. Now here, in the serous cystic neoplasm, it is like head, body and the tail, equal distribution. In the mucinous cystic neoplasm, body and the tail, this is having a higher concentration as compared to that of the head. And IPMN, this is predominantly present in the head of the patient. Then we have a central stellate scar, which is characteristically present in the serous cystic neoplasm. And then you have an eggshell calcification, which is again characteristically present in your mucinous cystic neoplasm. Then this is the main thing on which the MCQs are asked. So mucin negative, amylase is low, CA is low, the diagnosis is serous cystic neoplasm. Mucin is present, amylase is low, and the CA is elevated. This is what is your mucinous cystic neoplasm. And in the IPMN, obviously the mucin is present, and here the amylase and the mucin and the CA both are elevated. Okay, so yeah, this is how you will basically diagnose any patient with a cystic neoplasms of the pancreas. Now, and yeah, in the IPMN, what do you get? You get this characteristic fish mouth appearance. So it looks like a fish mouth, right? So it is, what is this? This is all the mucus which is basically coming out from the pancreatic duct. So as you cannulate it, the mucus which is coming out, that is what is called as a fish mouth appearance. This gives a fish mouth appearance, which is characteristically present in your IPMN. Now, let us talk about this particular condition, guys. What is this? So this is a patient who is suffering from cellulitis. What is this? This is a patient who is suffering from cellulitis. Now, what you need to understand over here is that, okay, what is cellulitis? So cellulitis is basically an infection, so of the skin. Now, if I just ask you what is the most common organism which is associated with this, so the most common organism which is associated with the cellulitis is streptococci. Streptococci. So beta hemolytic streptococci, this is the most common organism which is associated with the cellulitis. So what is the feature about the cellulitis, guys? Here what is happening, the dermis and the epidermis are involved, but also the subcutaneous tissue is present. So here the characteristic feature about the cellulitis is that along with the kind of epidermis and dermis, along with that there is also involvement of a subcutaneous tissue. So subcutaneous tissue is also involved. Are you understanding my point? So subcutaneous tissue is also involved over here. That is what you need to understand in the cellulitis. How will you manage this particular patient? Okay, now if you just examine this, okay, if you just examine this, now don't get confused with this line which they have drawn. They have just drawn it for their own significance. But if somebody asks you, are you able to, like, what is the feature of a cellulitis? Is there any particular demarcation line which is present? So please understand, there is no distinct demarcation which is basically present between the cellulitis and normal skin. Okay, so this is a feature of your cellulitis, and for the treatment, no doubt you will have to give this particular patient's antibiotics. Okay, you will have to give the patients antibiotics, that is no doubt. So the key features are streptococci, yes, it is involved. Here the subcutaneous tissue is also involved, and that is why the ear involvement is absent. Ears are not involved over here because in the ears we don't have much of a subcutaneous tissue. Here there is no distinct kind of demarcation between the cellulitis and the, like, between the affected skin and the normal skin. You don't have that particular distinct demarcation. In contrast to this, if you just talk about this particular condition, so what is this? This is your erysipelas. erysipelas. So what is happening over here, guys? Here you are having a distinct demarcation. If you're able to appreciate, you can very well say that, okay, here is the point where the erysipelas is kind of ending, and just beyond this, what you have a normal skin. You're very able to you are able to distinguish this. So let's talk about the erysipelas, guys. Again, this is your infection of the skin. Now, what is the organism which is associated with this? The organism which is associated with this is again a streptococci. It is again a streptococci, which is beta hemolytic streptococci, which is affecting. But the characteristic feature about this kind of erysipelas is, what is the characteristic feature? The characteristic feature of the erysipelas is, here only the infection is predominantly involving the epidermis and the dermis. It is not involving the subcutaneous tissue. So subcutaneous tissue is not involved, and because the subcutaneous tissue is not involved over here, that is why the ear is kind of normal over here. We don't get an involvement of a ear. Oh, I'm really sorry. Here we do get an involvement of ear. So ear can be involved over here. Are you understand my point? So because, yeah, we told you that in the cellulitis, ears are not involved, but here ears can be involved. Are you understand my point? It can be involved. Now, how do you manage, like, what exactly is the features about this? So that's fine. Okay. Now, another important thing which you want to write. So ears are involved, that is fine. And yeah, the distinct demarcation between your affected skin and normal skin, it is present, guys. Okay, so we do have a distinct demarcation between the affected skin and the normal skin. You understand my point? So this is what you need to understand regarding the erysipelas, right? Okay, guys, so next kind of question which I have for you guys is, let's say there is a patient who is coming to you with an ulcer like this. Now, this is a patient who is coming, and the patient is basically giving you the history that this particular ulcer, it is a non-healing chronic ulcer. It means that it has not healed for more than 3 months. So more than 3 months have gone, and still the patient's ulcer has kind of not healed. So whenever you have a patient with such a non-healing chronic ulcer, you suspect malignancy. You suspect that this might have converted into a Marjolin's ulcer. You suspect a Marjolin's ulcer, and if at all you suspect a Marjolin's ulcer, and if at all somebody asks you what is the next step in the management of this particular patient, so the next step which you will get in the management of this particular patient is what is called as a wedge biopsy. So what you need to do is, you need to take a wedge of a tissue of a normal skin and the wedge of a tissue of this particular ulcer, and you need to send it for the histopathological examination to evaluate whether any malignancy is developing over here or not. Okay, so if at all the malignancy is developing, and if at all, let's say, it comes out to be a Marjolin's ulcer, what is the most common type of the malignancy which will happen over here? So absolutely no doubt about it, it has to be a squamous cell carcinoma. So this is the most common type of malignancy which occurs in the Marjolin's ulcer. You understand my point? So yeah, this is what you need to understand regarding your non-healing chronic ulcer, right? I hope you got this point. Now let's move on to the next stuff. So here you have a patient who came to you with a dysphagia. So, okay, so what was the primary complaint of the patient? The patient came to you with a dysphagia. Now, whenever a patient comes to you with a dysphagia, what is the first investigation which you go for? The first investigation which you go for is a barium swallow. What do you go for? You go for a barium swallow in this particular patient. Now, on the barium swallow, you are finding such image, right? So patient came to you with dysphagia, you are finding this particular image. What are you finding on this particular image is, you are finding the following features. So on the barium swallow, you are finding that there is a shouldering of the esophagus. Okay, so you have a shouldering of esophagus. So what do you understand by shouldering of the esophagus? Are you able to appreciate this? So this is what is called as a shouldering of the esophagus. This bumpy lesions, these are what is called as a shouldering of the esophagus. Along with this, you also have something which is called as an apple core appearance. What are you having over here? You are having an apple core appearance. Now what do you understand by this apple core appearance? If you just complete this particular part over here, doesn't it looks like somebody has eaten the apple away and they have just left behind the core of this particular apple? So yes, that is what is called as an apple core appearance. And along with this, if at all they ask you about the rat tail appearance, so even this particular rat tail appearance is something which you see in the patients with an kind of carcinoma esophagus. Okay, so yeah, what is this particular rat tail appearance, guys? So rat tail appearance means like a lesion like this. So this is a contrast which is going inside over here. Okay, so this is a contrast which is going like this. Okay, so this is what is called as a rat tail appearance. Are you understanding my point? Yeah, so rat tail appearance, this is again a feature of your so if at all you perform a barium swallow and you get a features like the kind of shouldering of the esophagus, and you get the apple core appearance, and you get a rat tail appearance, if at all you get these points, what do you think that what is the diagnosis of this particular patient? The diagnosis of this particular patient is a carcinoma of the esophagus. Okay, so what is the diagnosis? The diagnosis is a carcinoma of the esophagus. Are you understand my point? Yeah, this is what is the diagnosis: carcinoma of the esophagus. This is the first investigation. It is suggestive of the carcinoma of esophagus. But if I ask you, what is an investigation of choice to diagnose? Okay, what is an investigation of choice to diagnose the carcinoma of the esophagus? What is the answer over here? What is the investigation of choice to diagnose the carcinoma of esophagus? So it is an upper GI endoscopy with biopsy, guys. Okay, so upper GI endoscopy with biopsy, that is the investigation of choice to diagnose the carcinoma of the esophagus. Now let's talk about other important points. So if I just ask you, what is the investigation of choice to look for the T and N stage in the patients with a carcinoma esophagus? What is the investigation of choice to look for T and N stage? What is the answer over here? The answer over here is endoscopic USG. So endoscopic USG is the investigation of choice to look for T and N stage of the carcinoma of the esophagus. And if I ask you, okay, what is this endoscopic USG, guys? What is this endoscopic USG? You are passing a probe from the mouth, and this particular probe is going till the lower part of the esophagus, and at this particular probe, what you're having at the end of this particular probe, you are having an attached USG probe. Okay, so you have a USG probe which is basically attached at the end of this particular scope. So this USG probe is kind of taking the USG kind of pictures, and this is what is telling you how much is the depth of the wall of the esophagus which has been encroached by this particular tumor or something like that. Okay, so the T and N stage, this is what is detected by an endoscopic USG. And lastly, what you have, guys, if I just ask you, what is an investigation of choice for the overall staging? For the overall staging, what is the investigation of choice? For the overall staging, the investigation of choice is PET CT, or you can have CCT. If at all PET CT is not given in the option, you can go in for a CCT. So I hope you got this particular point. On the first investigation, okay, so presenting feature is basically the dysphagia. This is what is your presenting feature. Then if I talked about the first investigation of your barium swallow, in this you will get this shouldering of the esophagus, apple core appearance, rat tail appearance, which is suggesting you that the patient is suffering from a carcinoma esophagus. Then I told you the investigation of choice is upper GI endoscopy with the biopsy. For the TNM stage, the investigation of choice is an endoscopic USG, and for the overall staging, the answer would be PET CT or a contrast enhanced CT scan. So, okay, once you have diagnosed that this is a patient who is suffering from a carcinoma esophagus, now what you need to do, you need to go in for a surgery. So, how will you manage this particular patient? So, obviously, you have to go in for an esophagectomy. Okay, so you have to go in for an esophagectomy, and once you basically go in for an esophagectomy, you need to replace the esophageal segment. So you need to replace the esophageal segment with something. So what is the thing with which you will replace this particular esophageal segment? Whatever the thing which we use to replace this particular esophageal segment is, that is what is called as a conduit. Okay, that is what is called as a conduit. Okay, that is what is called as a conduit. Now what you need to understand is that what are the different types of the, okay, I hope you understood this particular point, guys. So let's say this is your upper part of the esophagus and this is your whatever stomach. Now let's say there is a carcinoma of this particular part. So what you will do, you will just cut the esophagus over here, you'll cut the esophagus over here, you will take this out. But you cannot keep it like this, right? You will have to replace this particular part with something. You'll have to literally replace this particular part with something. So what do you basically use in order to replace it? Whatever thing you will use, okay, whatever you will use, this is what is called as your conduit, okay. Whatever part you use to replace it with, that is what is called as a conduit. Now what I want to ask you is that what are the different types of the conduits which you know of? So let us talk about this. First is the stomach. What do you have? The first is the stomach. Now what is this particular stomach, guys? This is the preferred conduit, or like the best conduit which you can talk about. So preferred or the best conduit. Now what you need to understand about this preferred conduit or the best conduit, what exactly do you understand by this particular stuff is, yeah, so this is what is the preferred, yeah, this is the best one, that's fine. Now what you need to understand is, this is basically based on what? So this is like the arterial supply for this particular stomach is, it is either based on the right gastric artery or a right gastroepiploic artery. If it all both are given in the option, you can go in for a right gastroepiploic artery. That is the preferred conduit which we use for this, okay. So in the stomach you have the preferred conduit is like the right gastric artery or the right gastroepiploic artery. This right gastroepiploic artery, that is the preferred conduit which we use for that, okay. Now one thing what you need to understand is that if at all, let's say there is a patient who is having an acid injury, so like patient has gone for acid ingestion, okay. If at all there is a patient who has gone in for an acid ingestion, what is going to happen? The acid is going to travel from the esophagus and ultimately it is going to come to lie on the stomach. So let's say the acid basically passed from this particular esophagus and it came to lie in the stomach. Now in the stomach, what is happening? From the esophagus it passed in, let's say, around 10 seconds, 30 seconds at the max. So in the stomach, what you have? You have a pylorus. This pylorus will not allow the acid to kind of go ahead. So if at all it is this particular acid is not allowed to go ahead, what is it going to cause? It is going to cause the scarring and it is going to cause the contracture of the stomach. It is going to cause the scarring and the contracture of the stomach, and because of this, okay, because of this, the stomach is not the preferred conduit for replacement of the esophagus in the acid ingestion patient. I understand my point. So in the acid ingestion patient, stomach as the conduit is not preferred. Okay, I hope you get this particular point. Stomach as the conduit is not preferred. So if we cannot use stomach as a conduit, then what do we use? So if at all we cannot use stomach as a conduit, we prefer to go in for a colon. Please understand this point, okay. So colon, what is colon? Colon, basically the left sided colon. So we basically use the left colon. So left colon, this is a preferred conduit. Okay, so left colon, this is a preferred conduit in patients with corrosive acid injury, okay. So yeah, like the left colon, that is a preferred conduit in the patients with a corrosive acid injury, okay. This is the best conduit, okay. That is what you need to understand. Now what is this particular kind of colon, left colon, based on? So what is the arterial supply for this? What is the arterial supply for the left sided colon? The arterial supply is, it is basically the left colic artery. Left colic artery, this is a preferred art, like this is what on which the colon is basically based as a conduit, right? So that is one thing which you need to understand. And then you have a jejunum. One thing which you need to understand regarding the jejunum is that this is only used for the short segment replacement. So if at all you have a particular part where you need a short segment replacement, you can go in for a jejunum. But the last point which you need to understand is that, what about the duodenum? Duodenum, it is not used as a conduit. It is not used as a conduit. Why? Because they have already asked you this once. They asked you which of the following cannot be used as a conduit, and the options were stomach, the colon, the jejunum, and the duodenum. So I hope you understood this point. Duodenum, it cannot be used as a conduit. Now let us talk about a metastatic esophageal carcinoma. So we can develop a metastatic carcinoma of the esophagus. So if at all you kind of develop a esophageal metastasis, then what is going to happen? After this, the life expectancy of this particular patient is less than 6 months. The patient is not going to survive for more than 6 months. And in this particular patient, what you can do, all you can do is a palliative management. Okay, so you can just go in for a palliative management in this particular patient. So what kind of a palliative management, what you will basically do over here, you have to go in for SEMS, SEMS. What is this SEMS? This is what is called as a self-expandable metallic stents. So what is this self-expandable metallic stent, guys? Now we know that there is a growth in the lower part of the esophagus. The patient is not able to eat food because of this, right? That's fine. So what we can do, we know that we cannot do anything to kind of save the life of the patient. No matter what we do, the patient is going to die in the 6 months. So all we can do is we can allow this particular patient to live whatever the 6 months he or she has with peace. How you can do that? By using this SEMS. By using this SEMS, what you can do, if you put this, this will basically help you in relieving the dysphagia. The dysphagia of this particular patient will be relieved. Okay, so this will help you in relieving the dysphagia of this particular patient, and that is what you called as a SEMS, that is a self-expandable metallic stent. And this is an image which you have of a self-expandable metallic stent that is very, very important, which you need to understand, right? I hope you get this particular point. So, well, guys, this is all for today's session. What I'll do is I'll just quickly revise because there were a lot of important topics which we covered today. So I'll just concise everything for you guys in, let's say, 5 or 10 minutes, so that all the topics have been covered by me in pretty much detail, guys. So yes, they will definitely help you in the revision. If you want, just stick around. In 5 to 10 minutes, I will be revising the entire topics whichever we have covered today. So first we talked about this bedsore. So it is pretty much evident this is a bedsore. Now what you need to understand is the main predisposing factor for the bedsore is the immobilization. So either the patient is having a pelvic fracture or the post-operative patient, or let's say the patient has developed a paralysis. Because of this, what is going to happen? The patient is not able to move. The pressure is kind of building up in the subcutaneous tissue, and if at all the pressure rises about the 30 millimeters of mercury, which is basically your capillary closing pressure, this is the point where the skin necrosis and the ischemia will set in, and ultimately the patient will land up into bedsore. So this is about the pathogenesis of the bedsore. I told you the most common site is the ischemium, but if they don't give this particular in the option, you look for greater trochanter. Even if the greater trochanter is not there, then the third option, like the third most common site, is the sacrum. Now many students get confused with this. Sacrum is not the most common site. The most common site is definitely the ischemium. I told you about the classification of the bedsore. I told you that in the stage 1 you have a non-blanchable erythema with no breach in the epidermis. So this is what you need to understand. In the second, you have a partial thickness loss of the dermis and the epidermis, and the 3 and 4 are pretty much simple. In the third, there is a full thickness loss, but the fascia is not breached. In the fourth, the fascia is breached, but the underlying bone and the muscles are kind of exposed in this. And what about the management of the bedsore? You first go in for a debridement. After that, you kind of put the patients on the negative pressure dressing, that is a vacuum assisted closure. What is the contraindication for this vac dressing? So active osteomyelitis, slough is present, and the malignancy. These are the contraindications for the development of a vac dressing. Then I told you about the log roll maneuver. This is a maneuver which you performed in the secondary survey. What you're basically doing in over here, you are rolling the patient and you're trying to evaluate the back of the patient. Why? Because you want to evaluate the spinal injury. So you are evaluating the back with the spinal injury. All you need to understand is that total 4 people are needed to kind of roll the patient, to perform this particular maneuver. Out of these, 3 are basically needed to roll this particular patient, and the 4th person is the one who is going to evaluate the back of this particular patient. And this is what is a part of your secondary survey. It is a part of your secondary survey. Now, what is the contraindication for performing this? Very, very important. Pelvic fracture. So pelvic fracture is a contraindication for performing this kind of stuff. Right. Then what do we have, guys? We have something which is called as a FAST. What is this particular FAST? FAST stands for Focused Assessment Sonogram for Trauma. Okay, so FAST basically stands for Focused Assessment Sonogram for Trauma. What do you basically do here? This is, okay, so what do you basically do? In the FAST, you perform a USG, which is what is FAST? FAST is basically nothing. It is a USG which you are performing in the emergency room. Okay, so what is this? This is a USG which you are performing in the emergency room. The aim of this particular stuff is, the aim is to look for intraperitoneal fluid accumulation. So aim is to look for intraperitoneal fluid accumulation. If at all the FAST is positive, it like the 100 ml of the fluid is present, you call that the FAST is positive. Then What are the probes which you can use? So you can use the epigastric. You have to keep this particular probe in the epigastric region to evaluate for the cardiac temporary, right hypochondriac, left hypochondriac to evaluate for the liver and the spleen, and in the pelvic cavity to evaluate for the pelvic collection. So this is how you will evaluate this particular patient. For the E-fast, you have something which is called as an extended fast. What is this extended fast? Here you keep your probe at 6 positions. So the 4 positions which are normal, then 2 more positions are right and the left lung field. So you also keep your kind of probe at these 2 particular positions. This is basically to rule out your kind of pneumothorax and the hemothorax. Okay, this is why you basically use that. Now, in this extended fast, E-fast, you get 2 signs which is called as a seashore sign. Seashore sign is a normal finding which is present in any individual, and if at all the patient is having a pneumothorax, then the sign which you get is a stratosphere or a barcode sign. Then we talked about the seatbelt injury. I told you that the most common organ injured in the seatbelt injury, that is the mesentery of the bowel. Forget about the mechanism, but yeah, please understand the most common organ injured is the mesentery of the bowel. The second most common injured was the duodenojejunal flexion. Please understand this. Right. Then I told you this is very, very important. For the blunt abdominal trauma, the most common organ injured is the spleen. I usually don't see any doubt in that, but many students get confused over here. Penetrating abdominal trauma, overall, the most common organ injured is the liver. It is not the intestine, guys. If they specifically mention the gunshot wound, then your answer will become small intestine, but otherwise it is just your liver. Then what you have a patient over here, like, so let's say there is a patient who is a diabetic patient who is kind of dysuric, there's a pain, there's a frequency, and the patient is also having a characteristic feature of a pneumaturia. So pneumaturia is present over there. In this particular patient, what is the diagnosis? The diagnosis is an emphysematous pyelonephritis. That is the diagnosis that you have over here. Right. So what are the things over here, guys? In the emphysematous pyelonephritis, this is basically a kidney infection, and here there is an air in the parenchyma. So what you need to understand, the predisposing factors is the diabetes mellitus. The most common organ which is kind of involved with this is an E. coli. If you perform an X-ray and the CT scan, you're able to find that there is a gas in this particular lesion. Okay. So yeah, that is X-ray on the CT scan is used to kind of diagnose it. For the treatment, you have percutaneous drainage with the antibiotics. That is the first treatment. And if at all the patient deteriorates, then you have to go in for a surgery. That is, you have to go in for a nephrectomy. And this is the one which is having kind of the bad prognosis. The mortality rate is high. It is close to around 50 to 60%. That's all about the emphysematous pyelonephritis. Now, this is important here. There is a patient who was subjected for an upper GI endoscopy. After performing an upper GI endoscopy, what happened? The patient developed a feature like this, and if you did an X-ray, you found a feature like this. So what is this? This is an esophageal perforation. The most common cause of this is an iatrogenic. Why? Because you're trying to negotiate your probe through this cricopharynx, which is the narrowest part of the GIT. The diameter is only 30 millimeters. If you're not able to do that, what is going to happen? You might rupture the esophagus, and that is the iatrogenic cause, which is the most common cause of your esophageal perforation. Another cause of esophageal perforation, which is not very common, but it can occur, is spontaneous perforation, which is the Boyer syndrome. So I told you the patient is going to come with the chest pain, subcutaneous emphysema, vomiting, all this stuff. If at all you perform an X-ray, you will be able to detect the subcutaneous emphysema. If at all you are able to see this, there will be a ginkgo leaf sign. What is this ginkgo leaf sign? So here the air is basically going along the fibers of the pectoralis major muscle, giving the diagnosis of a ginkgo leaf sign. So this is how the ginkgo leaf look like, and yeah, this is what is the ginkgo leaf sign. Then what do you have? You have investigation of choice is no doubt a CCT, that's fine. And then we talked about the Boyer syndrome. So what is happening in the Boyer syndrome? It is usually associated with the alcohol intake. Okay, that's fine. But just the presence of an alcohol intake doesn't give you a diagnosis of Boyer syndrome. The key feature is the vomiting should be occurring against the closed glottis. So vomiting should be present against the closed glottis. Okay. Now here what is happening? Because of this, there is an increase in intraluminal pressure. Because of this, the esophagus can respond in any of the ways. If at all there is a through and through rupture of the esophagus, that is what is called as a Boyer syndrome. If at all there is a longitudinal kind of tear along the axis of the esophagus, that is what is called as a Mallory-Weiss tear. Okay, here the patient is going to come to you with a hematemesis. I hope you get this particular point. Now, esophageal perforation, if at all is coming within 24 hours, you go in for a primary repair. If at all is coming after 24 hours, you go in for a divergent procedure. I have told you what is a divergent procedure, but yeah, if at all it is coming within 24 hours, you can go in for a primary repair of this particular esophageal perforation. Then I said that there is a patient who is coming to you with an upper GI bleed. Now, what did you do? You performed an upper GI endoscopy. On upper GI endoscopy, you found that the surrounding mucosa is kind of normal, but there's a torrential bleed which is occurring from one point. Now, this basically gives you a diagnosis of a dilophos lesion. Okay, so in the dilophos lesion, what do you find? You find a pinpoint source for the bleed, and the surrounding mucosa is kind of normal in this particular patient. So there's a gush of blood which is coming out, and the surrounding mucosa is kind of normal. That's fine. Now, what about the cause of this, guys? The cause is there's a submucosal pulsatile vessel. So what do you have? You have a submucosal pulsatile vessel which is present over here. This submucosal pulsatile vessel has eroded through the mucosa, and this is the one which has led to the bleeding. So it has eroded through the mucosa, and this is the one which has led to the bleeding, and this is usually occurring on the lesser curvature. Why? Because on the lesser curvature you have this particular left gastric artery which is a direct branch from a celiac trunk, and this has kind of eroded through it, and there has been a kind of pulsatile bleeding which has happened over here. Right. Then I talked about the treatment. So how will you manage it? So you have to go in for an endoscopy. This is how you'll diagnose it. If you find an active bleed which in front of your eyes, you go in for a cauterization. If at all the cauterization fails, you go in for an angiographic embolization. If that fails, you have to go in for a wedge resection. So yeah, this is how you'll manage a patient of a dilophos lesion. Okay, I hope you got this point. Now, that's fine. Right. So then I give you a scenario where let's say there is an obese patient who is coming to with a malabsorption syndrome, GI upset and all this stuff. Now the patient is coming to with a lower GI bleeding, that is a bleeding per rectum. So here what is happening, guys? And okay, then you did a kind of a barium swallow in this particular patient, barium enema in this particular patient, which gave you the sawtooth appearance, which is a very, very important finding. And this gives you a diagnosis of a diverticulosis. So I told you that in diverticulosis, the most common site is in the sigmoid colon. It is more common on the left side as compared to the right. But if at all they ask you a bleeding diverticula, so bleeding diverticulosis, that is more common on the right side. Okay, so if at all there is a right sided diverticula that is more likely to bleed, that is what I want to tell you. Then what do we have? Right, the diverticula, it can okay, it's just the presence of a diverticula in the intestine, that is what is called as a diverticulosis. Now the complication can occur in this particular diverticulosis, and it can kind of complicate into as a bleeding, or it can basically complicate as a diverticulitis. Okay, so diverticulitis, that is a complication of a diverticulosis. Now one thing which you need to understand, investigation of choice to diagnose a diverticulosis is a barium enema. Investigation of choice to diagnose a diverticulitis, that is a CCT, because obviously we cannot perform a diverticulitis, a barium enema in the diverticulitis, guys. Okay, so yeah, these are the few important points regarding the diverticulosis and the diverticulitis. Lastly, we talked about the cystic neoplasms of the pancreas. So here, what did I tell you? That if at all you perform an ERCP and you find an image like this, what is the diagnosis? The answer was IPMN, that is an intraductal papillary mucinous neoplasm. What is this? What you're seeing over here is a fish mouth appearance. A fish mouth appearance on the ERCP, it is a feature of your IPMN, intraductal papillary mucinous neoplasia. Now, in this, what you need to understand is that the cystic neoplasms of the pancreas, they can be the serous cystic neoplasm, mucinous cystic neoplasm, and the IPMN. These are the three kind of cystic neoplasms which we need to talk about. I told you that the serous cystic neoplasm, it is more common in the females. Mucinous cystic neoplasm, it is much more common in the females. But IPMN, the females and males are practically equal in incidence. I told you that the serous cystic neoplasm, head, body, tail, equal distribution. Mucinous cystic neoplasm, more common in the body and the tail as compared to the head. And the IPMN, that is predominantly occurring in the head of the pancreas. Characteristic feature which we see in the serous cystic neoplasm is a central stellate scar or a starburst calcification. Okay, that is a characteristic feature. In this mucinous cystic neoplasm, you get an eggshell calcification. So eggshell calcification is seen in the mucinous cystic neoplasm. Okay, then what do we see? That serous cystic neoplasm, mucinous cystic neoplasm, and the IPMN. Here, what you need to understand is that if at all the mucin is present, that is what is associated with the mucin, okay, obviously, but if at all there is a serous cystic neoplasm, it is serous, right? So the mucin is going to be absent. But at the same time, the amylase and the CA are also low in this. In the mucinous cystic neoplasm, because it is a mucin is present, and at the same time, the amylase is low, but the CA is elevated over here. And in the IPMN, again, intraductal papillary mucinous neoplasm. So obviously mucin is present, and it is amylase is high and the CA is high. This is the site from where most of the MCQs of your cystic neoplasms of the pancreas come, so please go through it. Then I talked to you about the cellulitis. Nothing great about it. It's an infection of the skin caused by the streptococci. It is involving the subcutaneous tissue as well, and that is why it doesn't involve the ears. But the point is here, there is no distinct demarcation between the normal and the abnormal skin, and if at all you have this particular, you have to think you have to go in for an antibiotic treatment. Okay, so this is a short topic of a cellulitis. Then we talked about the erysipelas. It is again the infection of the skin. The organism is against the streptococci. Here there's an involvement of epidermis and dermis, but the subcutaneous tissue is not that much involved. Here what is happening? there is a distinct demarcation between your kind of the normal skin and your affected skin. So yeah, the distinct demarcation over here is kind of present, and because the subcutaneous tissue is not that much involved, the ears can be involved in this, and the treatment is again for the antibiotic, nothing great about it. Then we talked about this. So only point which I wanted to make over here is that if you have a chronic non-healing ulcer more than 3 months, you suspect that a malignancy would have developed over here, and then you go in for a wedge biopsy, basically to rule out malignancy. If at all you get a malignancy, the most common type which you will get is a squamous cell carcinoma. Then I talked to you about this particular stuff. So if at all the patient comes to the dysphagia, you perform a barium swallow, and if at all on barium swallow you get this shouldering of the esophagus, apple core appearance, and the rat tail appearance, this is something which is suggestive of your carcinoma of the esophagus. In order to diagnose, in order to kind of confirm the diagnosis, you have to go in for an endoscopy with biopsy. And important point, investigation of choice for the T and N stage of the tumor is an endoscopic USG, and for the overall staging it is PET CT or a CCT. Okay, then I told you that obviously you'll have to go in for an esophagectomy, and after that you have to replace whatever the segment you have removed, right? So whatever the thing which you use to replace it, that is what is called as a conduit. So the one of the most important conduit is the stomach. That is the most preferred conduit in most of the particular scenarios. You need to remember the blood supply. So the blood supply for the stomach as a conduit is either a right gastric artery or the right gastroepiploic artery. If you want to choose between them, go for right gastroepiploic. That is a better answer. Now, if at all you have a patient with an acid ingestion, so it's logic that the acid will obviously go and accumulate in the stomach, and there it is going to cause the scarring and the contracture. So if at all here you want to use stomach as a conduit, it is not a good idea, obviously, right? So that is why we don't use stomach as a conduit in this particular patient. Here what you do is in the colon, you use colon, that is the left colic artery. Okay, the left sided colon is basically used as a conduit in this particular patient. Okay, yeah, so it's a preferred conduit in this particular patient. It's a corrosive acid injury, that is all fine. Yeah, in the corrosive acid injury patients. Now, if we talk about the arterial supply, so arterial supply of this particular colon is a left colic artery. The left colic artery is the arterial supply for this particular colon, and for the jejunum, it can be used for a short segment replacement. Duodenum, it is not used as a conduit at all. Okay, duodenum is not used as a conduit. Then we talked about, let's say if at all there is a metastatic carcinoma of the esophagus, the life expectancy is less than 6 months. We cannot do anything in order to save the life of this particular patient. All we can do is whatever the life the patient is having, we can just give him or her kind of a reasonably symptom-free life. In order to do that, what we can do, we can basically use this SEMS, that is a self-expandable metallic stent, which will basically help us in kind of relieving the dysphagia from this particular patient, guys. Okay, so yeah, that's all about this particular session. I hope you enjoyed it. This was a bit longer session, but I had gone in a bit more details of these particular topics, guys. So thank you so much, guys. I hope you're liking these particular sessions, and please do consider joining our Plus subscription. There are a lot many better things and good things which are happening on the Plus platform, and now you know that you can have Unacademy and kind of Prep Ladder subscriptions both together. You can have that. You can just go and kind of choose that particular section and you can evaluate. So if you are thinking of, let's say, 2-year or 3-year subscription or something like that, I think this is a good bet. Your best judge, you will take the best decision which is in your interest. But yeah, I hope this is a kind of a thing which I wanted to tell you. If you want to buy any subscription, please do consider using my promo code. My promo code is tr.pawan. You will get around 10% off, and yeah, if you wish, please do use that. Thank you so much, guys. It was indeed a pleasure interacting with you. Happy studying, guys, and see you soon. All the best. Bye, guys.